Hello everyone, I'm Dr. Chu from Taiwan. It is my honor to be invited by the Society to deliver this lecture at such a prestigious event. My presentation today is titled Fat Grafting for Breast Augmentation, Safety, Graft Retention, and Recent Advancements. I will share my experience in autologous fat grafting, AFG, for breast augmentation over the past 20 years. On the left, you can see the photos of my clinic, which won the silver prize at the Italian A-Design Award for interior design. If you ever visit Taiwan, you are welcome to visit my clinic for academic exchange. Among the papers I have published, in addition to facial plastic surgery, there are four main research directions: how to increase the survival rate of fat graft, how to objectively evaluate volume changes after fat transplantation, how to use autologous fat to correct chest defects after breast implant removal, and how to successfully complete breast augmentation in extremely thin women. On the right, you can see the journal covers featuring my published papers. Currently, I serve as a reviewer for several important aesthetic and plastic surgery journals, including Aesthetic Surgery Journal, Aesthetic Plastic Surgery, Cancer Research, Dermatologic Therapy, Journal of Cosmetic Medicine, and over 10 other journals. The first topic I will discuss today is the safety concerns associated with autologous fat grafting. First, let's examine the current medical literature regarding whether autologous fat grafting for breast augmentation increases the risk of breast cancer. This is a 2016 systematic review published in Aesthetic Surgery Journal. It includes studies on autologous fat grafting for breast augmentation published between 1996 and 2016. After exclusions, 22 studies comprising 3,565 patients were included in the statistical analysis. The results showed an average graft survival rate of 62.4%, a patient satisfaction rate of 92%, and a surgeon satisfaction rate of 89%. The conclusion stated that AFG is a promising method in achieving autologous cosmetic breast augmentation with satisfactory volume retention and satisfaction rates. Complications and radiological findings are comparable to those after implant augmentation. Among the 22 studies included in this systematic review, 2 of them were written by me, published in 2014 and 2016. In 2021, another systematic review was published in Aesthetic Surgery Journal, including 64 studies from 21 countries, with a total of 5,162 patients. Among these patients, 2 developed breast cancer post-AFG, leading to a breast cancer incidence rate of 0.04%. According to the American Cancer Society, the average risk of a woman in the United States developing breast cancer sometime in her life is about 13%. Thus, the incidence of breast cancer after AFG is lower than that of the general population. The conclusion of this study stated autologous fat grafting significantly improves breast aesthetics, with a 1-year survival rate of 60 to 70%. Only 8% of procedures resulted in clinical complications, and 5% of patients required biopsy due to abnormal clinical or radiological findings. Overall, only 1.56 sessions were needed to achieve the desired outcome. Among the articles cited in the systematic review, there are 3 papers written by me, which were published in 2014, 2016, and 2018. Beyond evaluating the safety of AFG in healthy women, we must also consider whether it is a safe reconstruction option for patients with a history of breast cancer who have undergone mastectomy. This study investigated the safety of autologous fat grafting in breast cancer patients and concluded AFG or lipofilling appears to be an oncologically safe technique with low morbidity in women with a history of breast cancer. A 2016 review article followed 6,260 breast cancer patients who underwent AFG with a follow-up period exceeding 10 years. The average local, regional, and distant oncological recurrence rates after breast reconstruction with AFG were 2.5% and 2.0%, respectively. The conclusion stated the safety of AFG is not compromised as cancer recurrence and complications are not observed. A 2022 systematic review further confirmed that overall survival, disease-free survival, and local recurrence rates in post-mastectomy patients undergoing AFG were comparable to those not receiving fat grafting. According to current evidence, AFG is a safe technique for breast reconstruction. Take-home message: autologous fat grafting is a promising method for cosmetic and reconstructive breast augmentation. AFG does not increase the risk of breast cancer in healthy women and does not raise the risk of local recurrence or distant metastasis in breast cancer patients post-mastectomy. Next, we will address another question. Does adding stromal vascular fraction, SVF, containing stem cells to autologous fat grafting increase the risk of breast cancer? It is generally believed that poor fat graft survival are due to the loss of a significant number of adipose-derived stem cells, ADSCs, during the liposuction process. Compared to natural adipose tissue, the concentration of ADSCs in harvested fat is nearly halved. Therefore, some researchers propose isolating and purifying ADSCs from a portion of the harvested fat and reintegrating them into the graft to enhance its survival. This approach is known as cell-assisted lipotransfer, CAL. In surgical practice, we can directly isolate stem cell-rich components from a patient's adipose tissue, known as stromal vascular fraction. There are two primary methods for SVF preparation: the enzymatic digestion method using collagenase and the mechanical process method. These two techniques yield slightly different products. The enzymatic digestion method produces SVF by breaking down adipose cells and fibrous tissue, resulting in an SVF lacking extracellular matrix, ECM. In contrast, the mechanical method involves repeated shifting of the harvested fat to disrupt adipocytes, followed by centrifugation. After centrifugation, the fat separates into four distinct layers, from top to bottom: oil, ECM, SVF, and aqueous components. The combination of SVF and ECM is referred to as SVF gel. Adipose-derived stem cells have powerful therapeutic potentials in humans. In 2014, Elos conducted a study on an animal model of human breast cancer and found that injecting ADSCs into tumor cells did not affect the growth of breast cancer cells. However, if ADSCs were injected into the periphery of the tumor would stop growing and disappear after 3 to 8 weeks. So he believes that ADSCs may appear promising for their use as a substance against breast cancer cells. A 2016 systematic review published in PRS Journal explored the oncological safety of cell-assisted fat lipotransfer for breast augmentation. The conclusion stated, although several studies based on cell cultures or animal models have demonstrated that adipose-derived stem cells may promote breast tumor growth and invasion, human studies have shown no signs of cancer development in any enrolled subjects. All cysts and nodules reported were benign and self-limiting. Malignancy was ruled out in all cases of calcifications. Similarly, a 2021 review article suggested that while ADSCs can theoretically promote tissue repair through pluripotent activity, paracrine signaling, immunomodulation, and proangiogenesis, most clinical trials favor the use of CAL in breast reconstruction without increasing oncological risk. A 2023 review article further indicated that while ADSCs alone may enhance the proliferation and the invasiveness of breast cancer cells in vitro and in vivo, when co-transplanted with fat tissue, no such tumor-promoting effects were observed. In another experiment, ADSCs were found to induce DNA damage in breast cancer cells via paracrine signaling, inhibiting tumor growth, slowing cell progression, and promoting cancer cell apoptosis. Some studies even reported that ADSCs could differentiate into natural killer-like cells, exhibiting anti-tumor activity. So conclusions. While experimental studies have shown that ADSCs can promote the biological behavior of breast cancer cells, most clinical studies indicate that fat grafting does not increase the recurrence of breast cancer. ADSCs in breast cancer treatment hold promise as a safe and potentially beneficial therapy for breast cancer patients. Take-home message. Adipose-derived stem cells are stem cells purified from adipose tissue and have multiple differentiation potentials, including differentiation into adipocytes and other cell types. Therefore, adding ADSCs to transplanted fat is believed to enhance graft survival. While animal and cell studies have shown that ADSCs can promote the proliferation and migration of breast cancer cells, clinical studies have yielded different results. When ADSCs are co-injected with fat, no significant enhancement of BCC growth has been observed. Recent studies even found that ADSCs can exert various functions to inhibit the growth of breast cancer cells. Next, I would like to talk about the graft survival issue that everyone is most concerned about. A recent systematic review published in PRS in 2024 analyzed 35 studies involving 3,757 patients. The average volume of fat injected was 300 cc, and the mean fat retention rate was 58%. The study also noted that the PRP and SVF-enriched fat grafting resulted in higher graft survival rates. An earlier systematic review estimated the average fat graft survival rate to be 62.4% and concluded that AFG complications and radiological findings were comparable to those observed in implant augmentation. A 2021 review article in Aesthetic Surgery Journal reported that AFG survival rates ranged between 60 to 70%. Regardless of the exact retention rate, all studies highlighted the high patient satisfaction associated with AFG. Regarding the efficacy of cell-assisted lipotransfer, a 2021 systematic review published in Aesthetic Plastic Surgery compared CAL to conventional fat grafting. The review included 6 studies with 353 patients. Surprisingly, the analysis found no significant difference in final graft survival between SVF-enriched AFG and conventional AFG. While different SVF isolation methods and different injection percentages have an impact, more research is needed to answer this question. Among the 6 international studies included in the systematic review, one was my study, published in 2019. In my 2019 study published in Aesthetic Surgery Journal, we utilized 3D laser scanning to evaluate post-grafting volumetric changes. Our findings indicated no statistical significant difference in final fat retention rates between SVF-enriched grafting and conventional grafting. What's even more exaggerated is that even if the treatment is divided into 2-stage operation, 200 cc of fat is extracted at the first operation, stem cells are cultured in vitro and then added to the transplanted fat, and a prospective study is conducted using a double-blind control method. There is still no statistical difference in the final survival rate. Take-home message: the average long-term fat graft survival rate for breast augmentation is 50 to 70%. Some studies suggest that PRP and SVF can improve graft retention, while others report that CAL does not significantly enhance survival rates. Further research and longer follow-up periods are necessary to confirm the efficacy of CAL. Finally, I would like to share a few ongoing research areas aimed at improving fat graft survival. The first is fasting preconditioning. Animal studies have found that if the experimental group fasts for 24 hours before fat transplantation, the survival rate of fat increases by 20%. The possible mechanism is that the longer fasting time induces VEGF and produces the angiogenesis effect. This study believes that this can be used as one of the strategies to improve the survival rate of fat during AFG. Another study investigated the effect of N-acetylcysteine, NAC, enriched tumescent solution on graft survival. In this experiment, liposuction was performed on the thigh as the donor site. The experimental group received tumescent solution containing NAC, while the control group received standard tumescent solution without NAC. Fat harvested from each respective solution was then injected into different breasts. 6 months post-procedure, MRI volumetric analysis was conducted to assess graft retention. The study utilized a split body design where 145 cc of fat containing NAC in the tumescent solution experimental group was injected onto one breast, while 145 cc of fat obtained by control solution was injected into the contralateral breast. Results showed a 12% higher fat survival rate in the NAC-treated group. Researchers attributed this outcome to NAC's role as a free radical scavenger, which effectively suppresses post-transplantation inflammatory cascades triggered by soft tissue manipulation during fat grafting. This method holds clinical significance due to NAC's low cost and the potential to improve fat graft viability through antioxidant-mediated protection against ischemia reperfusion injury. Finally, I would like to talk about our ongoing research exploring the incorporation of botulinum toxin into fat grafts. A 2024 systematic review concluded that BTXA enhances fat graft survival by stimulating angiogenesis and reducing muscle contraction. Additionally, BTXA improves fat graft retention by promoting vascularization and enhancing their differentiation on adipose-derived stem cells. What is the optimal dose of BTXA to increase graft retention? The suggested dose of BTXA is 0.08 unit per cc fat graft. To apply this dosage to AFG for breast augmentation, for every 100 cc of grafted fat, 8 units of BTXA are required. For 300 cc of fat per breast, 24 units are needed per side. So if you want to inject total 600 cc of fat to the breast, you will need 48 units of BTXA. Take-home message. Various methods can enhance AFG survival rates. PRP and SVF enrichment are options, but may be costly. Additional alternatives include fasting preconditioning, NAC-enriched tumescent solution, and BTXA supplementation, all of which show promising results. The above is the content of my presentation today. I am sorry that I am unable to attend the meeting in person due to some reasons. I apologize for the inconvenience caused. Thank you all for listening, and I wish you all good health and happiness. See you soon.